Dr. Ranjan is the president of the National Neonatology Forum, and he's going to be speaking to us about trained birth attendant cover in labor room and impact on safe childbirth. Sir is the chief neonatologist, Meenakshi Hospitals, Bangalore. He's the president, National Neonatology Forum of India 2021. He has got more than 110 scientific papers published in both national and international journals, 149 presentations at both national and international scientific meetings, and author of 22 books of neonatology and pediatrics, several contributions in various textbooks. So we look forward to hear from you, sir. Over to you.
Hello, everyone. Yeah. I bring greetings from National Neonatology Forum. I'm extremely happy to be a part of this the annual day, which probably is called Advocacy Day, also with all various organizations being present here. Thanks to Dr. Vijay Agarwal and the team from CAHO for inviting me and giving me an opportunity to speak. The original topic, which was given to me, I will come to later why it was changed, is the pediatrician cover in labor room and impact on safe childbirth. India is a unique country. It has an annual birth rate of 27 million, which is we adding the continent of Australia every year to our country population wise. The neonatal mortality is 21 per 1,000 live births, and for many, many years, the important causes contributing to these newborn deaths have remained as preterm births, low birth weight, perinatal asphyxia, early onset sepsis, and congenital anomalies. More than 70% of the neonatal deaths occur during the first week of life. We can proudly say that our institutional deliveries have crossed 80% of the total deaths. But our antenatal visit rate is still just above 50, that is 4 prescribed antenatal visits, though 21%, just short of quarter, do get the full visits. But overall, it's only 52%. So with this background, I feel the onus is on us with 80% institutional deliveries to provide safe and respectful delivery, mother and newborn health care. In this context, definitely pediatricians' presence should and would ensure these important points: communication and counseling, preparation for resuscitation and resuscitation if required, using cost-effective interventions, cost-effective mandatory practices, and many a times we forget that shifting the baby as appropriate is the responsibility of the pediatrician. Documentation, needless to say, is one of the most important aspects of healthcare delivery. And a few points on the respectful newborn care at the end. Now, communication and counseling. Pediatrician has an important role to communicate with the obstetricians initially about the antenatal history, what is the important points there which has to be noted prior to the delivery, and preparations to be done, the team to be formed. The risk factors of the mother, which has to be taken into account, and details of the baby, starting from whether it's multiple pregnancy or single pregnancy, single baby, from there to the weight, gestation age, etc. And this has to be in a proper way, in a very nice way, with respect and honoring the sensitivity of the parents at that particular moment. Has to be told to the parents, counseled about the condition of the fetus, whether there could be a need for resuscitation, possible and probable complications, and prognosis as applicable. There are a few interventions which I'm going to mention, not in detail, but these are, I feel, really cost-effective interventions which will improve the quality of the newborn in the immediate neonatal period and in days to come. One of them is a single course antenatal steroids, well tried out, and it has become a standard of care for women at risk for preterm delivery. It has to be given to infants, mothers who are going to deliver less than 32 to 34 weeks of gestation. I feel that this intervention, which is actually performed by the obstetrician, is the responsibility of the pediatrician to make sure that the mother gets. And our compliance rate of this, though it is almost 80-90% in the urban areas, overall in the country, it's about 62%, which is above the international average. The second one I want to mention, these are medical aspects, but one should always remember this. Magnesium sulfate for the pregnant woman at risk of preterm birth for neuroprotection of the fetus. This single intervention reduces the cerebral palsy risk by 33% if given to the mothers who qualify for it. It's not expensive. The numbers needed to treat NNT for, if you take as 34 weeks as the cutoff point, is just 56, and at less than 30 weeks is 46. Simple intervention, monitoring is easy, and it is done just before the delivery in the labor room. Set protocol is there. I will not go into the detail, but it reduces the risk of cerebral palsy by 33.13%. The earlier intervention has picked up well, antenatal corticosteroids, but magnesium sulfate to women at risk of preterm has still not taken off in India. Another very cost-effective intervention, which a pediatrician should and would ensure, again performed by the obstetrician, but for the benefit of the baby and the ease of the management of the baby by the pediatrician, is delayed or deferred cord clamping. Minimum of 1 to 3 minutes. It is known to decrease neonatal anemia, infant anemia. Significant here because India has the highest rate of anemia amongst children between 9 months and 1.5 years. So the benefit of this delayed and deferred cord clamping has been found to last even to that age. Delivery onto the abdomen of the mother. This is again a very, very important aspect which in the rural areas or in the semi-urban areas may be practiced, but I feel that there is some amount of hesitation both in the doctors and the mothers about delivering the baby onto the abdomen or the lower chest of the mother. There are a lot of benefits here. The skin-to-skin contact at an early stage, which happens, has a lot of benefits, starting from encourages breastfeeding, improves breast milk secretion, baby is calm, stabilizes the baby's breathing, regularizes the heartbeat, helps the baby feel safe. Lot of benefits are there, and this has to pick up. That is delivery onto the abdomen of the mother, both in normal delivery as well as cesarean deliveries. Even the resuscitation, all the initial steps, everything can be done there, unless and until the baby requires advanced resuscitation, which is only 1 in 100 babies. Oxygen, we now know, is a drug, and we have to be very careful. Hyperoxia is as dangerous or more dangerous than hypoxia. So the time where 100% oxygen was used with an ambu bag is gone. 100% oxygen versus room air. 3 meta-analyses. First breath and cry of newborns resuscitated with 100% oxygen was significantly delayed by more than 1 minute, up to 2.02 minutes. And this is very detrimental to the baby in the short, medium, and long term. The disconcerting fact is that prolonged persistence of oxidative stress in infants resuscitated with 100% oxygen. So the recommendation now is more than 35 weeks of gestation, room air. Less than 35 weeks of gestation, start with 21 to 30 and titrate with the saturation. Anyway, so resuscitation with oxygen higher than 65% is not recommended. Now in the bottom, this has crept in here in between. That is the temperature management in labor room. Hypothermia is a silent killer. On its own, hypothermia may not cause mortality unless it's very severe, but it adds on to the baseline problems the babies may have, that is perinatal asphyxia, sepsis, and hypothermia adds on to that, and it is very, very dangerous. It is a very avoidable complication, and special care has to be taken about hypothermia, starting from simple things like having one set of towel, not just one towel to wipe the baby and another towel to wrap the baby after the wiping is over. Preheating the warmer in the resuscitation corner and making sure there is no loss of heat by conduction, convection, or radiation from the baby. Reducing the, in posh labor theaters, reducing the temperature of the room when as soon as the baby is born, because the temperature is usually kept for the benefit of the mother and the health caregivers, the staff. But when the baby is born, it should always be reduced. Now, going to the next important this thing is, I feel as time goes, ambu bag will be replaced by TP's resuscitator, because there is more and more evidence that ambu bag, the compressions which you give are not controlled, and the early damage of barotrauma in low birth weight babies and premature babies can be very detrimental. So small equipments like TP's resuscitators should become a standard of practice. Now, non-invasive ventilation, continuous positive airway pressure, is a very simple method. I'm very glad that the staff in the Essence are being taught and encouraged to use this. And there's a lot of capacity building going on. NNF is holding a lot of non-invasive ventilation workshops. So it is very well known that CPAP given in the delivery room itself to preterm babies and small babies avoids conventional ventilation, reduces the number of days needed in ventilation, reduces the need for surfactant, and early discharge from the hospital. Now, I mentioned this earlier also. One of the responsibilities of the pediatrician is to make sure the baby gets post-resuscitation care, not just resuscitate and leave the room. He should make sure, depending on the type of assistance the baby has received, if it is simple initial steps only, baby is left on the chest of the mother, skin to skin care is continued, breastfeeding is initiated as early as possible. If the baby had needed positive pressure ventilation, observe just for an hour or so in the postnatal ward or in the step down nursery. If the baby has had advanced resuscitation, observe in the intensive care for a short duration and do anything if required or transfer it back to the mother. Stabilization and temperature regulation, either soon after delivery or till the baby reaches its destination in the postnatal ward or NICU, is the responsibility, and that prevents a lot of morbidity later on. There is enough to say about breastfeeding and no prelactial feeds. The two surrogate markers we know are the early breastfeeding within an hour and exclusive breastfeeding for 6 months. And our figures are not very pretty. Only 42% in India are breastfed within 1 hour, and only 55% of mothers breastfeed exclusively at 6 months. We need to improve on this. The most disconcerting fact is that the percentage of breastfed infants replaced or given supplements with formula feeds within 48 hours, please correct that, within 48 hours is nearly 20%. Who does this? Why does this happen? Are the two major questions we have to look at. So 20% of the babies, when they are in the hospital itself, before 48 hours, are fed with formula feeds. Please remember this, and we have to do something about this. I left resuscitation till the end because resuscitation is something which is extremely important. And India has a very structured neonatal resuscitation program. IAP and NNF together are doing the neonatal resuscitation, and we have trained until now from 2009 to 2020 1,22,000 healthcare professionals have been trained. That includes both advanced and basic resuscitation. We have about nearly 3,000 to 4,000 trainers who will continue this resuscitation program and continue training. It is very, very important because perinatal asphyxia is still the second largest cause of neonatal mortality. Now I come to the question why the title had to be changed. Do we have a pediatrician attending each and every delivery? No. And I don't think it will happen in the near future. So we have a gap there. But we should remember only 90% of the babies need only the initial steps. 10% need some form of assistance to breathe, like tactile stimulation and maybe bag and mask ventilation, positive pressure ventilation. Only 1 out of this 10% will advance or go on to advanced resuscitation, even though the earlier steps have been done systematically. So that is 1 in 100. So if we take care of the basic neonatal resuscitation amongst all the other health givers, that is nurses, midwives, and paramedics, then we can fill that gap. And that is why the title has been changed to a trained person. It need not be the pediatrician. A trained person should be present who is trained in basic resuscitation. However, access to a pediatrician who will be needed if advanced resuscitation has to be carried out should be planned before attending any delivery. Now, coming to some of the finer points, when we are talking about respectful, safe delivery, privacy, we should always give importance to this, whether we are providing the care, whether we are in the labor ward or in the theater. And most of the time now, mothers are awake when cesarean section is done. We have to be very careful. We have to respect the privacy and the sensitivity of the mother who is undergoing a major procedure as far as she is concerned. Maybe the anesthetists and the obstetricians and the pediatricians are quite adept and okay with that, but we should respect the mothers and her fears about what may happen. Always involve the parents in the care plan right from the beginning, in the antenatal period itself, and even in the NICU or in the nursery. Give them ample chance, give them the option, encourage them to take part in the care plan of their baby. Pain is something which we tend to overlook sometimes. Adequate pain relief is important for every procedure on the baby. Earlier I have said this, delivery onto the abdomen, skin to skin care, zero separation is what is now recommended. This will lead to early breastfeeding, and early breastfeeding will reduce a lot of morbidity. And whenever the baby is being cared for in the hospital, developmentally supportive care should be provided. A mother taking the baby home, especially when she is a prima gravida, preparation for discharge is required. Do's and don'ts have to be explained to her. The danger signs have to be explained to her. She should be encouraged to come back for follow-up at regular intervals, and the immunization according to the schedule should be explained to her and should be provided. Home-based neonatal care will go a long way in improving our neonatal health and in preventing neonatal or infant morbidity and infant mortality. So what is the way ahead? Trained nurses trained in basic resuscitation who are taught essence of the first golden minute, what has to be done, and the first golden hour following the delivery. Extend the training to include essential newborn care and tell the parents about what they should do and what they shouldn't do when they are discharged. We have several government programs starting from Navajath Shishu Kalyan Karyakrama, Laqshy, and the next step of Laqshy Plus or Muskan is going to be launched. I am proud to say that NNF will be an active part of this program, and mentoring and monitoring of these trained nurses is very, very important. So now I can say that trained attendants, both from the obstetric side and the neonatal side, have to be there at each and every delivery, and that should be our goal. We may not achieve it today, tomorrow, but if we keep at it, if we continue our training, if we renew their knowledge and skills, we mentor and monitor them, we will definitely have a more safer and respectful childbirth and newborn care. One thing I want to, before ending, inculcate quality initiative early in the training, inbuilt in all the programs, and encourage HCPs to take up small projects and get into this habit of quality initiative. And only with quality we can achieve the daunting tasks like single digit newborn care, etc. We have been doing capacity building, we have been doing skill transfers, knowledge transfer. So there is some spice missing from the sambar, and that is the quality. So quality is very, very important, and we should seriously think about it. NNF is doing a lot for this, and we are having zonal meetings for all our members to learn about quality. So in the end, I would say, initially we wanted only salvaging babies. Then we went to the step of salvaging intact babies. Then we said you have to follow evidence-based practices to do this. You have to follow, in a country like India, cost-effective interventions. And now finally we say all this should be done in a safe and respectful manner. Thanks for your patience, and thanks for giving me an opportunity. Thank you.
Thank you very much, dear sir. That was brilliant. And I particularly liked your last sentence where you said the spice that is missing in the sambar, and that's probably what is quality. And we as an organization, we are committed to promote quality in this country. And I think it's too many hands that needs to come together to spread the wave of quality and patient safety here. It's such a large country. And as you rightly said, we are adding the population of Australia every year from our country. So brilliant talk, sir, brilliant talk. And I was wondering as to how we are going to relate, bring in the trained personal concept and as a replacement to pediatricians. I think you did it well. Thank you very much for that eye opener and for your time. It's a blessing to us that you could spare your time to be with us today. Wishes to you, sir. Thank you.